Welcome to another interesting episode, completely under the aegis of Mumbai Hematology Group, and we are extremely proud to bring it to you. The man on the screen is the gentleman responsible, none other than our program director, Professor Dr. M.B. Agarwal. We know him very, very well. He just finished very interesting webinar yesterday evening, 10 things that a hematologist must not do. That was again very, very enriching. And today he is back under the aegis of Mumbai Hematology Group with another interesting webinar. Sir, you are an institution, teacher of teachers, 250 plus webinars post-COVID. No wonder you have been getting accolades across all. For us, you are the one who were the savior during COVID time and post-COVID time, kept it so enriching. A very warm welcome to Dr. Nikita Mehra as well, our guest speaker today. A warm welcome to chief guest and guest of honor, Dr. Chirag Shah. May I request Professor M.B. Agarwal sir to take it forward from here. And warm welcome to all the discussants as well.
Thank you, Dr. Manoj, for those kind words, and good morning to one and all. Today, our guest speaker is Professor Nikita Mehra from Chennai. She will speak to us on plasma cell leukemia, its molecular pathogenesis, treatment, and the recent nuances. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash and Mr. Kalpesh and their team from Perfect Square, the Executive Committee of Mumbai Hematology Group, our chief guest of the day, Dr. Chirag Shah, our guest speaker, Professor Nikita Mehra, all our discussants who are themselves very eminent hematologists and medical oncologists, and you participants for sparing your Sunday morning, afternoon, evening, depending upon which part of the world you belong to. We have today participation registration from 25 plus countries. Just before we begin our webinar today, it's my pleasure to introduce to you what we are going to do from tomorrow for 1 week. And that is an update from EHA 27th conference, which was a hybrid conference held in Austria. And we bring up the best of that to you as challenges in hematology. This will start from tomorrow, that is 4th of July at 6:30 p.m. or rather 6:25 p.m. and will go on for 1 week, that is 10th of July. 3 lectures a day, 21 lectures in all by international guest speakers. And if you finish your work early, be with us at 6:25 p.m. tomorrow. If you miss out on any kind of information in the form of emails or messages, the best way to keep contact with our academic activity is to visit our website. And it's very simple to remember, www.MHG, Mumbai Hematology Group, that is mhgindia.com. So for all the links, for all the programs, backwards, forwards for next 1 month to 2 months, all displayed there. Every Sunday we do a quiz, and if you have an important quiz that you'd like to share, this is the platform for you. You can yourself come and ask the quiz and solve the quiz. We also have a weekly program in the form of case presentation, case of the week. And if you have once again an interesting case to share, please, the platform is yours. Once again, you can do it yourself. Our discussants displayed here alphabetically are all important personalities in this field. And they are there to interact with Professor Mehra today about plasma cell leukemia. To briefly introduce them to you, Dr. Abhishek Dudatra from Ahmedabad, Dr. Aditya Shah from Mumbai, Dr. Aditya Jandyal from PGI Chandigarh, Dr. Ankit Rayani from Cure Ahmedabad, Dr. Dharma Chaudhary from Sanar Gurugram, Haryana, Dr. Deepanjan Haldar from Jupiter, Mumbai, Dr. Gunjan Prasad from Apollo, Kolkata, Dr. Nidhi Dixit from Apollo, Kolkata, Dr. Jayachandran from Cancer Institute, Adyar, Dr. Prashanta Bhatt from KMC, Mangaluru, Colonel Dr. Rajat Kapoor from Command Hospital, Kolkata. Dr. Roshni Pandey from Mahakoshal, Jabalpur. Dr. Shilpa Prabhu from Majumdar, Bangalore. Dr. Srinath Shirsaga from Global and Somaya, Mumbai. Dr. Srijesh from PGI, Chandigarh. Dr. Stalin Bala from Nizams, Hyderabad. Dr. Tejaswini Gudipande from Majumdar, Bangalore. Dr. Vikas Goyal from Sanjeevan, Raipur. And Dr. Yashwant Kashyap from AIMS, Raipur. It's my privilege to introduce our guest of honor and the special guest of the day who is going to inaugurate our webinar. And that's my friend, Dr. Chirag Shah. Who doesn't know Dr. Chirag Shah? If you have anything to do with hematology, hemato-oncology, medical oncology, and transplant, he's an important towering personality for you. He's Director, Department of Hematology, Oncology, and Stem Cell Transplant at Apollo Hospitals International Limited, Ahmedabad. He has a rich experience of having performed more than 200 hematopoietic stem cell transplants. He successfully established the Department of Hematology and Medical Oncology at Apollo CBCC Cancer Care, Ahmedabad, way back in 2004 and added hematopoietic stem cell transplantation program to it in 2007. With numerous publications in peer-reviewed international and national medical journals, he's authored a book on cancer evaluation and management in Gujarati in 2014, and this book has had an overwhelming response, and why not? The English version of the book was released 7 years ago in 2015, and that's equally popular, even more popular. By now, he has published over 20 books on various cancers, and that's a phenomenon. He's a member of the Indian Society of Medical and Pediatric Oncology, American Society of Hematology, and American Society of Clinical Oncology. During last 10 years, he has run the first NGO-managed palliative care center of Gujarat, known as Karunalaya. It's managed by Shyam Oncology Foundation. This center is meant for cancer patients. Giving you a background of Dr. Chirag Shah, he's a product of Baroda Medical College, Vadodara, Gujarat, India. And subsequently, he got his training from the prestigious institutions like Albert Einstein College of Medicine, Montefiore Medical College, New York, Wayne State University, Detroit, Michigan, in US for 7 years. He's a diplomat of American Board of Hematology and Medical Oncology. It's my privilege to invite him to inaugurate our today's webinar, give us some words of wisdom. And Chirag, we are extremely thankful to you for having spared this time, having accepted this invitation and being with us. Over to you.
Thank you, sir. It is my pleasure and privilege to inaugurate this conference and to be considered worthy of this task by the Mumbai Hematology Group and the and Dr. M.B. Agarwal. For the students and for the younger consultants, I would like to share a little secret of success in any medical field, and that is to follow the principle of patient first. Now, this may sound very simple, but if you religiously practice this, this will solve most of your ethical and professional dilemmas, and it will improve you as a professional, will make you more knowledgeable, ethical, and caring, and improve job satisfaction and respect from your colleagues. So, to give you an example, you have to become a patient advocate. So for that, we have to know a lot more than what we know to pass the exams or to give a very good presentation. This goes far beyond that. So when, a lot of people have questioned that the person who was very bright academically and why he is not so successful in practice. And this is where the difference comes primarily, that we have to understand how to apply the knowledge to the patient, and how to make him comfortable in taking decisions. So we have to get into his shoes, and that means we have to personalize the care for practically each and every patient. So for example, when you do a test, you have to realize what are this patient's needs, and if you were in his shoes, would you be doing this much of tests like various prognostic markers, NGS panels, etc., MRD monitoring? And do we have the right to become an academician at the expense of a patient? Then comes interventions. We have to again remember that various new drugs or even old drugs or procedures, for example, BMT, in a case of monosomy karyotype AML, how much value would it add? Is this intervention going to be palliative? How much more lifespan? At what cost? Or what quality of life? So overestimating benefits can lead to unnecessary suffering for a person, even if he is affording or reimbursed. And in India, we know that many families are pushed below poverty line due to various medical treatments, and cancer is one big area. Underestimating benefit can lead to loss of life or loss of potential years of life or opportunity to reduce suffering. So the fun of medical practice includes managing this balance. And we have to constantly, this is a lifelong learning, because the patients are different, their aspirations, their support services, their finances. So we have to take into account so many factors. But this is what sets you apart from other physicians who don't become truly patient advocate. So when you follow this patient first principle, you will also improve as a human being, because now you will have to keep your ego and insecurities aside, because you have to give him result. And this will help you develop better working relationships with your colleagues, staff, and of course your patients. And now your work is going to be result oriented rather than just process oriented. You are not doing the checklist of 1, 2, 3, 4 things that you know. You are trying to make actual success in patient's life. You are result oriented, and that will make lot of things clear for you. And once your goal is clear, all the good things that you need from life will certainly follow. Apply this principle in few cases when you have a dilemma regarding either a test or intervention or an ethical issues, and as a pilot test, and I'm sure you will realize the benefits. And also look at how your role models are applying these principles in their practice. Good doctors keep patient interest first. They know this intuitively. Thank you.
Thank you, Dr. Chirag Shah, for those words of wisdom. Beautifully crafted speech with lot of messages, not only for youngsters, I would say for all of us. Even if we can do 5% of what you have suggested, probably we will achieve one more stone ahead of us. Thank you so much for being with us. We move on to the second part of the day, and that is our Sunday quiz. This is for everybody. It's not necessarily only for the students. You make your attempts, whatever you feel is the answer, do forward. If you are the first one with the correct answer, you get the prize and recognition. And all those who give the correct answer, we will be reading out their names in the order in which we have received the correct answers. That itself is inspirational to a lot of other youngsters, and more participation takes place. So please don't hesitate in forwarding your reply. You have to email it to the email ID that is put up over here, mbagarwal1@gmail.com. So even if you get a correct answer after some time, doesn't matter. Please forward it. We will now put the quiz to you. So today's quiz is related to inclusions in red cells. I'll be showing you 6 peripheral blood films. One or more of the films have hinge bodies. You have to do something very simple. You have to just email. Each film has been given a number. So you have to email me the number of the film in which the red cells are showing hinge bodies. If it is 1, then you will be sending the number 1. If it is more than 1, you will be sending the number 1, 2, 3, whatever. So a film or films, the red cells are showing hinge bodies. So today's quiz is very simple. If you know how the hinge bodies look, you have to just send that number. Email ID mbagarwal1@gmail.com. Here are the 6 blood films. I'll keep it on. Out of these 6 blood films, if you feel any one or more are showing hinge bodies, send that number 1, 2, 3, 4, 5, 6. 1 or more numbers, just email them. Okay, so I suppose we move on. And now we have the weekly case profile. And I'm extremely delighted, Dr. Ifat Jamal, from your email. Dr. Ifat Jamal has volunteered to present his case in the forthcoming webinars. And Dr. Ifat, I'd like to tell you 2 weeks from today, you can do this. So Sunday, 2 weeks from now, just email your slide deck of the case and you will be presenting your case to us. Now today's case profile. Raju, 8 years, boy from Rajkot. Burkitt's lymphoma with high tumor load. He was transferred to Lilavati Hospital for management of an acute onset breathlessness, having a normal X-ray chest and a normal heart. In addition, he had dark-colored urine, vomiting, and there was renal shutdown. At Rajkot, he had received treatment to prevent tumor lysis syndrome, followed by a brief course of corticosteroids. His vitals were stable. The pulse oximetry, 98% on ambient air. Examination showed severe pallor, icterus, and cyanosis. Blood counts, hemoglobin was 5.2, retic count was 12%. Smear showed bite cells, polychromasia, and NRBCs 12 per 100 WBC. Bilirubin was 1.7, indirect more than direct. Haptoglobin was low, 7, and LDH was sky high, almost 5,000. Urine showed hemoglobinuria. So this much was clear that the boy was actively hemolyzing. This was intravascular hemolysis, causing drop in hemoglobin and hemoglobinuria. And he was probably breathless because of his low hemoglobin. AKI was also confirmed. The workup for tumor lysis syndrome was negative. So that was not the cause of his AKI. Looking at his hemolysis, the direct Coombs test was negative and there were no malarial parasites. But he was severely deficient in G6PD. And that gave us the etiology of hemolysis. However, that was not all. His arterial blood gases showed a pH which was okay, 7.4. His PO2 was 65 and PCO2 32, bicarb of 22. CT chest was done again and it was normal. His methemoglobin level was 12.8%. So that was second very important large finding, what was keeping him breathless. We were looking for the trigger that caused hemolysis in a patient of G6PD deficiency and also the trigger that caused methemoglobinemia. Our resident doctor noticed something in the discharge note of Rajkot, which gave us this trigger, both for hemolysis and methemoglobinemia. And maybe some of you can wonder, what was that in the discharge card of Rajkot that gave us the complete diagnosis with respect to what caused hemolysis in this boy who didn't have G6PD and who developed methemoglobinemia. And this was a word written there that this patient had received one injection of rasburicase to prevent tumor lysis syndrome. He was managed with Paxos, vitamin C, oxygen, folic acid, avoiding further rasburicase. And we didn't give him methylene blue, which is the standard treatment for methemoglobinemia, because he was G6PD deficient. Avoided all the drugs contraindicated in G6PD deficiency, supported his kidney, and he needed dialysis for 5 days. He settled in 2 weeks, and then he was transferred back to Rajkot to his medical oncologist for further management. The reports of hemoglobin M and cytochrome B5 reductase also came through, and these reports were negative, confirming that this was acquired methemoglobinemia. Rasburicase is known to produce methemoglobinemia, especially if you are G6PD deficient. For last almost a decade, you have access to generic rasburicase, and therefore cost is no more an important issue. And the knowledge that one vial is enough to produce to prevent TLS, rasburicase use has become liberal. In this boy, of course, it was scientific because he had Burkitt's lymphoma, high-grade lymphoma, massive tumor load, and a young child. So chance of his getting into TLS was extremely high. So rasburicase use was fully justified. However, rasburicase is contraindicated in G6PD deficiency. This is sometimes forgotten, and especially when there is a medical emergency, like in this boy. You want to prevent the TLS and AKI, and you can rush with rasburicase without waiting for the report of G6PD. We accessed PubMed after we saw this patient, especially for methemoglobinemia. And some time ago, that was almost about a year ago, there were 33 published cases of rasburicase-induced methemoglobinemia. Many of these were of African American origin, staying in US, and were males. It's expected because G6PD most commonly is seen in males. 2 were females. 7 of these were pediatric patients. Only 5 did not have G6PD deficiency. That tells you that methemoglobinemia due to rasburicase is predominantly in G6PD deficient individual. Outcome of all the cases was not known, but 2 of them were clearly reported to have died. It's a serious problem. In our patient, clinical cyanosis, despite normal pulse oximetry, but decreased oxygen saturation on arterial blood gas measurement made us conscious that this could be methemoglobinemia. Intravascular hemolysis was the cause of AKI. Even in Mumbai, there was no lab tumor lysis syndrome, so that was not the cause of AKI. We would have loved to use methylene blue, but we couldn't do that because of G6PD, and that prolonged the course of methemoglobinemia, as we had to manage only with vitamin C. Diagnosis of G6PD deficiency may get masked in some cases when somebody has got reticulocytosis, which are young RBC, and they may have enough G6PD. And if somebody has received recent blood transfusions, then that can also mask G6PD. 2 published cases had received methylene blue and they deteriorated. One of them was found to have G6PD 4 months later, when the effect of reticulocytosis and blood transfusion vanishes. So if you find G6PD normal, you must repeat it after 4 months. Exchange transfusion was thought of in our patient, but child settled without it. These are few important references. First one is distinct mechanism for rasburicase-induced hemolysis and methemoglobinemia. Second one is rasburicase-induced methemoglobinemia case report, literature review, and proposed treatment algorithm. And this is very helpful. This particular article, it helped us. There's an Indian article, very exciting title, Blue cures blue, but be cautious. So methylene blue cures the cyanotic episode due to methemoglobinemia, but be cautious. First, look at G6PD. Methemoglobinemia and hemolysis in a patient of G6PD, secondary to rasburicase. Lastly, exchange transfusion as the treatment of rasburicase-induced methemoglobinemia in a G6PD deficient patient. So the learning point from this case was always do G6PD quantitative assay before administering rasburicase, however may be the emergency. To think of methemoglobinemia in an appropriate situation when there's a discrepancy, and to avoid methylene blue in the treatment of methemoglobinemia if you are suspecting G6PD, even if you can't document it because of reticulocytosis or blood transfusion. And now we come to the most important part of the day, and that is Professor Nikita Mehra's lecture. It's my privilege once again to introduce her, and like Chirag, I must say that the Indian audience does not require any introduction of once again this very important personality. She's Associate Professor of Medical Oncology at the prestigious Cancer Institute at Chennai. She divides her time between patient care, in which she focuses on the adult hemato-oncology, especially plasma cell disorders, on which she's going to speak today, just one aspect of it, plasma cell leukemia, and also the adult bone and soft tissue sarcomas. And her other important aspect of life is the research that she carries out in the Department of Medical Oncology at the Institute. And this research is focused on epigenetics and the development of biomarkers in the subject she likes the most, multiple myeloma and its precursor states. She holds a DM in medical oncology from Cancer Institute Chennai itself. Her previous training included MD in General Medicine from Sri Ramachandra Medical College, Chennai, where she graduated with a gold medal. She has trained and worked at leading institutions, including Beth Israel Deaconess Medical Center, Boston, and in Mumbai at PD Hinduja Hospital. Last year, she was awarded the Young Investigator Award by the International Myeloma Society for the exemplary abstract based on her work regarding M protein detection. And this has become a very hot subject today, the M protein detection by MALDI TOF mass spectrometry. Not all of us are fortunate to have the mass access to mass spectrometry to pick up the MRD through minute quantities of M protein in this field. But she does not only have an access, but she did her work, which she got the award. Today, she's going to lecture on plasma cell leukemia, molecular pathogenesis treatment and recent advances. And there's already a lot of enthusiasm amongst the faculty present here and the audience to listen to her. So now it's time to hand over the platform to her.
Good morning, sir. Thank you so much for the very kind introduction. A very good morning to all the eminent faculty members who are. So there is much to learn from your kindness. Thank you so much for the very kind invitation. I'd like to begin with thanking Dr. Chirag Shah, sir. Very, very nice words, and especially your point on how important it is to be a patient advocate. I think we do everything in order to better the lives of our patients in terms of clinical work and research. So today I'm going to talk about plasma cell leukemia. We're going to briefly go over the molecular pathogenesis, the treatment, and recent advances. So as most of you already have gone over the history of plasma cell leukemia, it was initially described as leukemia lymphatica plasmocellularis. So this was by two professors, and here we have a picture of the professor from Ukraine, Professor Glozinski. And again, arsenical compounds were used for treatment of the first presentation of plasma cell leukemia. There was very brief responses followed by relapse and death. Going into the epidemiology, as we're very well aware from the Globocan data and data that was out on the global burden of multiple myeloma, among the incident cases and deaths in the world, the highest numbers are actually occupied by India, China, and US. Okay, one will, of course, say that the contribution is because we have larger patient numbers given our population. Having said that, India does feature in the top 3 in terms of the total number of incident cases. Of course, there are a lot of issues with under-reporting, under-diagnosis, because a lot of the times patients don't have access to money for diagnostics. Sometimes serum protein electrophoresis might not be sufficient. A lot of other, and of course, we're aware of the heterogeneous type of representation. In plasma cell leukemia, the total contribution of plasma cell leukemia is only about 0.4 to 2%. And this is data from SEER. This is from, there is a European HemaCare project and the Danish National Multiple Myeloma Registry, which actually covers 100% of the population. As you're very well aware, plasma cell leukemia is divided into 2. There's the primary plasma cell leukemia, where plasma cell leukemia presents de novo even before the patient has had a diagnosis of multiple myeloma and treatment for it. And secondary plasma cell leukemia, which is patients who've received treatment for multiple myeloma or the other, sometimes a smoldering myeloma converting into a myeloma, and after several lines of therapy, developing a plasma cell leukemia. What we will concentrate on very largely today will be on primary plasma cell leukemia, which contributes to about 60 to 70%. Now, the numbers of secondary plasma cell leukemia, or the incidence, is going up, and this is really because patients are living longer, especially in the West. There's access to newer treatments, so there are more patients presenting with secondary plasma cell leukemia. So actually, the contribution to secondary plasma cell leukemia is now going up, and it's almost 50%. Going into the diagnostic criteria of plasma cell leukemia, there was a seminal paper that was published in 1974 by Professor Kyle. And here, plasma cell leukemia was defined as a patient with plasma cell disorder, especially multiple myeloma, having 20% circulating plasma cells. When you look at a differential count, and a total plasma cell count in the peripheral blood of at least 2000, or 2 into 10 to the power of 9 per liter. Now, in 2013, this definition was actually changed, where you required either of the 2 criteria. So this was a definition that was modified by a recommendation by the International Myeloma Working Group and was endorsed by the WHO as well. Again, the diagnosis of plasma cell leukemia, the most simple, the most inexpensive way of diagnosing plasma cell leukemia is a conventional cytology. And most of the studies from the West, from anywhere across high income or low income countries, are on cytology, that is conventional cytology, a peripheral smear based assessment. There are other ways to diagnose plasma cell leukemia, and they include a slide-based immunofluorescence microscopy, multi-parametric flow cytometry, and a next-gen flow. Again, you have a few studies, but have they really entered or gotten into the definition of plasma cell leukemia? Not yet. Also, it's very important to bear in mind that the cutoff and the percentages of plasma cells should be explored and further validated by these technologies. So we're really going to talk about studies that have looked at the regular conventional cytology, which is what we probably practice in most of our centers or institutions. So this was a study that came out in 2021, and this was a position paper by the International Myeloma Working Group, where they were really looking to modify the definition further. So as you're very well aware, you have more than 20% plasma cells earlier that was defined as plasma cell leukemia. But here on the basis of two studies, so there was one, like you can see on the table, on the left side is a study from Spain, and the right is a study from the US, from Mayo Clinic. And when you look lower down at the median overall survivals, you can see that if the plasma cell percentage in the peripheral blood was 5% and above, you can actually see the survivals going down very low. From the Spanish study, 5 to 20% plasma cells, the median overall survival is 6 months. For more than 20%, it's 14 months. And again, when you look at the Mayo study, if it was 5% and above, the median overall survival is 13%. Now you compare this with the group where there are no circulating plasma cells, the survivals are close to 50 months. Now there are, of course, a few caveats in this particular position statement, and that is that the information is taken from retrospective studies. And the Spanish study actually had a shorter follow-up. It was about 28 years. From the US study, the follow-up was higher. But again, a lot of the patients actually received older chemotherapy protocols. They were not even cytotoxic multi-agent chemotherapy protocols. PI IMiDs were far less. They represented less than 50%. And again, patients receiving a transplant. Having said that, the final recommendation was really to move towards more than 5% circulating plasma cells, as calling it a plasma cell leukemia. Now, why is plasma cell leukemia? Is it molecularly very different from multiple myeloma? And the answer is yes. I will show you some clinical data also on its comparison with myeloma. But what you really see is about 70-75% have IGH translocations. Now, in multiple myeloma, we always categorize the cytogenetic risk stratifications as those having hyperdiploides, and that is an increased chromosome number, which usually involves the odd number chromosomes. And you have the IGH translocations, which involves chromosome 14 and its various partners. So about 70 to 75% actually have IGH translocations in plasma cell leukemia. Now, in that, 1114 actually 1114 occupies a very high number. It's almost about 50%. We will talk about the significance of this subsequently. The other prognostic factors that are represented a lot more in primary plasma cell leukemias are deletion 17p or a TP53 mutation, gains in chromosome 1q, 3 copies, or amplification, that is 4 or more copies, or deletion 1p. So these chromosomal 1 abnormalities are also very, very frequently seen. They're upwards of 50%, and monosomy 13. Now, as you're very well aware, deletion 17p and these chromosomal 1 abnormalities are secondary cytogenetic abnormalities. They start happening later. Now, in plasma cell leukemia, they have a lot of complex, there are complex cytogenetics. So there are a lot of chromosomal abnormalities that are present upfront as well. Now, even in terms of the mutations, NRAS and KRAS mutations are seen a lot more frequently de novo, that is at diagnosis of primary plasma cell leukemia. Immunophenotyping, CD38 and 138, just like multiple myeloma, they're almost universally present. But what you have more frequently is CD20, CD23, CD28, CD44, and CD45. Of course, do you require an upfront flow cytometry for all patients with plasma cell leukemia? Essentially, when you go by all the guidelines, you don't need a flow cytometry at diagnosis. There are conditions where you can see a lot of polyclonal plasma cells as well, sepsis, serum sickness, etc. But that really hasn't led to having to do a flow at baseline, because when you have a bone marrow, you can look at the clonality of plasma cells by IHC as well, and several other techniques. You can look at CD138, you can look at the light chain restriction. So flow cytometry might identify more cases with a plasma cell leukemia. But is it going to change too much? Possibly not, because if it is 5%, 10%, you are going to identify it by morphology. Now, again, in plasma cell leukemia, the markers that are less frequently seen are CD9, CD56. So CD56 is actually an important adhesion marker to the bone marrow. So as soon as everything starts detaching from the marrow, CD56 becomes negative. So it becomes a very important prognostic factor. CD117 and HLA-DR are also represented. That is, the expression of these antibodies are low. Again, when you look at the gene expression profiling, when you look at this heat map, where there is a green color that's represented for plasma cell leukemia and myeloma, you can really see that the expression profiles are very different between plasma cell leukemia and myeloma. And there is a category called non-coding RNAs, which are actually becoming a very, very important sort of epigenetic mechanism for multiple myeloma. Non-coding RNAs can be microRNAs, they can be long non-coding RNAs, and that really depends on the size. And what essentially happens is, in plasma cell leukemia, you have a lot of these RNA splicing genes that can be dysregulated in plasma cell leukemia a lot more than myeloma. Now, this is a slide on the methylation patterns in plasma cell leukemia. And what you really need to take home from the left hand side, the pictures on the left side, are that the orange color is basically a hypermethylation. That is, the methylation levels are increased. And for the trainees that are in attendance to the program, as you are aware, methylation leads to basically the silencing of genes. Now, what you see in in plasma cell leukemia, everything is in blue on the left side diagram. You actually see hypomethylation. So there is reduced methylation, and therefore some of the genes are not silenced. So what you can have is some of these oncogenes that normally have to be silenced, they're no longer silenced. So there is a lot of oncogenic activity. There's less tumor suppressor gene activity. And what you see on the right side is again a heat map, but it essentially shows that methylation is very, very different in plasma cell leukemia versus multiple myeloma and MGUS and normal plasma cells. Now, why is it so important to to further reduce the number of plasma cells in the peripheral blood to define it as plasma cell leukemia? It's very nicely explained in the study from Mayo Clinic that was out in 2018. Now, what you see on the left side, the Kaplan-Meier curve, is they've looked at overall survival with multiple myeloma in the contemporary era. That is, patients, a lot of them were on novel agents. This was in patients who were diagnosed and treated after 2001. And what you see is, if a patient had 5% or more circulating plasma cells, the median survival is very low. It's only 1.4 years. Whereas for multiple myeloma, it is 5.7 years. Now, when you come to the right-hand side, even if you are to look at or categorize multiple myeloma as standard risk and high risk, Again, the patients with plasma cells, circulating plasma cells of 5% or above, their overall survival is only about 1.5 years. Versus in a high risk, it's about 4.3. So of course, a lot needs to be done. A lot of protocols are being used to intensify treatment, but is that really translating into better survival in plasma cell leukemia is what we are going to see. A very quick note on the presence of circulating plasma cells, regardless of the percentage. So there are studies which have defined 1 to 4% as early plasma cell leukemias. So if you have a patient with the presence of plasma cells in the peripheral blood, regardless of the percentage, they seem to far worse than the patients with multiple myeloma and no circulating plasma cells. This is another study from Mayo Clinic, and they've looked at the trends in survival of patients with primary plasma cell leukemia. Now, this was really possible through the SEER registry. Now, the SEER registry, it basically covers about 30% of the US population in terms of the cancer registries for, all the cancers are very well represented. And up until the early 2000s, the SEER registry actually had data on plasma cell leukemia by itself. And primary plasma cell leukemia. But after that, they've stopped looking at plasma cell leukemia. Even the plasma cell leukemias are coded under multiple myeloma. But really what the study showed is that from 1973 to 2006-9, you can see that the survival has doubled. Is it good enough? No, it is never going to be good enough. The survival is only 12 months from about 5 months. But what you can see on the right side in terms of the survival is this improvement in survival is far better in the age group that is 65 years and above. But again, when you look at the overall survival of 3 years or more, across all the subgroups, only about 10% are surviving at the end of 3 years on the basis of this study. So really, what I will be able to show you in the next few slides is that there is very limited data. And a lot of the guidelines are actually are put down. They're all on the basis of expert opinion. There are very few randomized clinical trials that are available. I'll show you about 2 or 3 phase 2 studies, but a lot of them are retrospective. A lot of them are data that's clubbed together from various centers and various registries. And yes, multiple myeloma, in the multiple myeloma clinical trials, plasma cell leukemia, unfortunately, is a key exclusion criteria. And really the worry from the position paper that came out on redefining circulating plasma cells to 5% is that even the subgroup that is up until is between 5 and 20% will probably start getting excluded. So we do need to have a lot of studies, definitely national, but also international, on representing this group better and them having studies as well. Unfortunately, that isn't the case right now. What is the goal of treatment? It is immediate cytoreduction. So this is the first phase 2 study that was published from the European centers, the first phase 2 on primary plasma cell leukemia. And here they really looked at lenalidomide and low-dose dex. So it was a small study, 23 patients, 4 cycles of Lendex, followed by a transplant, followed by lenalidomide maintenance. And if a patient was transplant ineligible, Lendex for 8 cycles was given, followed by len maintenance. And in the transplant eligible group, the progression-free survival was about 21 months. In the transplant ineligible, it was half of that. It was only 10 months. And again, the p-values was not significant. But when you look at the overall survival among the patients who were transplant eligible, the overall survival or the p-value was, the survival was not reached at the time of analysis, but for transplant ineligible, it was only about 12 months. So essentially the take home from this slide is, yes, you need to offer a transplant for sure to patients who are eligible. Now, this is another study from the IFM, from the French group, and this really looked at intensifying treatment, because here you're looking at plasma cell leukemia. They wanted to give some anthracyclines. So what they've done is, this was a study on about 40 patients. They've given alternating cycles, 3 cycles of PAD, which is a proteasome inhibitor, liposomal doxorubicin at 30 mg per meter square. This was a 21-day cycle. So it was just given on day 3, dexamethasone versus and alternating that with Cyborg. Now they've looked at 4 cycles of this, and then they've looked at responses. Now, if the response was at least a stable disease and if the patient was transplant eligible, the patient had an autologous stem cell transplant. Now, again, the analysis was really on patients who, there was further analysis on patients who were able to get to a transplant. Now, at consolidation, after an autologous transplant, an allogenic transplant was done if the patient was eligible and if the patient had a VGPR. So they had a RIC allo. And if they were not eligible, then they gave them a second auto transplant. Now, in this study, they've given a maintenance, that is a consolidation VRD to all the patients, followed by lenalidomide maintenance or lenalidomide maintenance for 1 year. I'm sorry. So it was VRD or lenalidomide maintenance strategies. And here again, you look at the overall response rate, it's about 70%. A high number were refractory to induction. Now, when you look at the SWOG data on multiple myeloma where VRD was given, the number of patients that are refractory is very low. It's far less than, it's about 5%, 7%. But here the refractoriness to induction was 26%. So from this strategy, now they were really hoping to see better outcomes in the study because an anthracycline was also added. Now, the median PFS in this study was 15 months. The median overall survival was about 3 years. So a 1-year PFS, about 60%, and a 12-month overall survival was seen was about 75%. But what you really see is, again, the relapses are very high. So 33%, 1/3, have died due to a progressive disease. There was more recent data from this particular study on the long-term follow-up. So the median progression-free survival for those who had an auto-allo was 18.5 months, whereas those with a tandem auto and maintenance was 50 months. So they really go to show that tandem auto is working well. We will see which groups do well subsequently. And again, in the median overall survival for an auto-allo, it was about 39 months, and a tandem auto followed by maintenance was not reached. So tandem auto with maintenance is certainly a good strategy. There are several studies that have showed not giving maintenance is definitely going to lead to higher relapses. So you have to maintain them all through. Lenalidomide alone may not be sufficient. It's probably better to give a PI IMiD plus minus DEXA. Now, this was one of the first few studies on they really looked at data from several centers. This is from CIBMTR. So this is from the US, and they've looked at data on auto transplant and allogenic, and they really want to see if allogenic is better. So again, if I'm talking about auto, they've really clubbed patients that have received a single auto or some who've received a tandem auto. The numbers are certainly not equal between the two categories. And again, for allo, a few have received a consolidation allo, but many of them have actually had an auto followed by allo. Now, what you see is a 3-year progression-free survival of auto transplant looking a little better, not statistically significant. It's 34% with an auto, and for an allo, it's 20%. And the cumulative incidence of relapse with an auto, 60%, allogenic, about 40%. What you see here is in auto transplant, this is very old data. This is data from 1995 to 2006, where they've taken close to 200 patients. But what you really need to appreciate with older data is that very few receive novel agents. So in this data, only 5% have had bortezomib, and only about 25% have received thalidomide. Now, the 3-year overall survival with an auto is 64%, and allo looks very low. It's about 39%. They further looked at single versus a tandem auto, and the tandem auto looks better. It's about 84%. Single auto, the overall survival is about 56%. Now, very old data, non-relapse mortality at 3 years is 5% with an auto, but it's 40% with an allogenic. We do have some updated data on non-relapse mortality, which has come out more recently. But this is old data where the non-relapse mortality was 40% in the West. Now, this is data from, it's a single center study from Stanford. And again, the numbers are very small. It's only about 15 patients. They've looked at the outcomes with auto or allo in the era of novel agents. Now, what you can really see is in the progression-free survival and the overall survival, that is the two figures on top, the Kaplan-Meier curves. Allogenic, which is the one that's represented in blue, looks better. The progression-free survival is 18 months. For an auto, it's 6 months. And overall survival for an allo is 40 months and auto is 19 months. But none of this is statistically significant. And really over here, they go on to conclude that we don't see differences between auto and allo. Even though it looks numerically better, they do not consider this as statistically significant. Now, this is data that is more recent. Again, from several centers in the US, CIBMTR has come together, and this was data that was out in 2018 in leukemia. Again, they've clubbed all the, it's between 2008 and 15 that they've looked at patients. The sample size is larger, it's about 350. They've looked at the overall response rate. So earlier you looked at an overall response rate of about 60-65%, and that has now increased to 87% in the novel agent era. The 4-year non-relapse mortality for an auto transplant is 7% versus it's 12% for an allo. The 4-year relapse again continues to be very high, regardless of the strategies, lots of novel agents used. It's 76% in auto and 70% in allo. The 4-year progression-free survival and overall survival between the two arms seems to be about the same. So it's about 18-19% progression-free survival, and the 4-year overall survival is about 30%. Now, what you really see at the bottom is also the survival curves. They're all sort of they're stuck to each other. So again, they're not seeing a lot of differences between auto and allo. And again, they go on to conclude that allo, the role is probably, it's not as, it isn't really faring so much better than an auto. But here they very nicely define the predictors of overall survival. And that is Karnofsky's performance status of more than 90. And if a patient achieved a VGPR prior to transplant. So if the patient achieved a VGPR or better, that really goes on to show better overall survival outcomes. Now, this is a very recent study that came out in June, and this is the largest study on plasma cell leukemia, primary plasma cell leukemia. This is the sample size is about 751. Now, from this study, they've done a lot of predictions where they're comparing between auto and allogenic transplant. But really, the most important take-home message from this slide has to be that a patient can actually have a tandem auto and do well and do very well when compared to the other arms if the patient has had a complete response, a CR. So they've got to have less than 5% plasma cells, normal immunofixation, serum and urine has to become normal, and the absence of M protein. Now that group does very well with a tandem auto. You don't have to, so if you look at the graph over here, what is those dotted lines in green on top is a tandem auto in CR. Now what comes a close second is tandem auto allo in CR. Now the third category is tandem auto allo no CR, and patients who've not achieved a complete response, if they just have a tandem auto, they seem to do the worst. So again, I'd like to once again reiterate the importance from this study, of the importance of achieving a CR. So if the patient has had a CR, you could always offer an auto. If the patient, for several reasons, sometimes our discussions with patients' caregivers, it's very difficult to even convince them to have a tandem auto, and auto allo becomes very far-fetched, and logistics, the availability of donors can be a lot of issues. So if the patient has had a CR, we could offer an auto. But if the patient has not had a CR, in that setting, it becomes very, very important to offer an allogenic after an autologous stem cell transplant. Now, venetoclax, of course, like I mentioned, 1114 is present in almost 50%. And as we're very well aware of venetoclax, it is a potent BCL2 inhibitor. It is a BH3 mimetic. And T1114, as we know, is characterized by high BCL2 expression. Normally, there is low BCL-XL and MCL1 mRNA expression. Now, this leads to a higher sensitivity to BCL2 inhibition. But you can have instances where MCL1 expression can actually be increased. It's not low. So MCL1 overexpression can actually lead to venetoclax resistance. So bortezomib is an MCL1 inhibitor, and there lies the role of combining bortezomib with venetoclax. Now, this is a very nice study that came out in 2018, and this was from the Czech Republic, where the patient had primary plasma cell leukemia and had failed 2 lines of treatment. On a compassionate basis, they were able to source venetoclax. So they gave 1200 milligram on 21-day cycles, and at the end of 9 cycles, they have they've done a lot of analysis. I mean, they've looked at all the biochemical parameters and PET CT and MRD evaluation. Everything was negative with just single agent venetoclax. They've done very nice work to ensure venetoclax was sensitive. So they've looked at the expression profiling of BCL1, BCL-XL, and MCL1. They've looked at the ratio of BCL2 and BCL-XL, BCL2 and MCL1 by quantitative PCR on flow cytometry on sorted, FACS-sorted plasma cells. Now, only when they were able to see that this drug was sensitive, they were able to kind of get this drug. But beautiful results. The publication was out in October 2018, and the patient was MRD negative and PET negative with just single agent venetoclax. There is another study from Mayo Clinic that has looked at basically DKPD. They've along with they've looked at daratumumab, bortezomib, dexamethasone along with venetoclax. In that also, they've been able to show that the patient became MRD negative at the end of 4-5 cycles and was PET negative. But there you really can't tell what the single agent responses of venetoclax was. This study very nicely tells you the importance of single agent venetoclax in 1114. But again, very important, if possible, to look at the expression of these other BCL2 family proteins that can actually, if they are overexpressed, it can reduce the sensitivity of venetoclax. Now, this is another study that is by Van de Donk et al. This is the EMN12 HOVON study. We've got very preliminary results from this in 2019, where they've looked at primary plasma cell leukemia and they've given KRD. So they've done 4 cycles of KRD, followed by tandem auto transplant, followed by KRD consolidation and KR maintenance. Or if the patient is ineligible, then 8 cycles of KRD followed by KR maintenance. Excellent response rates. The VGPR was 80%, stringent CR was 33%. They also go on to show that the regimen is safe, and we don't have a lot more results from this study, but based on all the recent publications, these study results are very eagerly awaited. The stringent CR is 33, which is excellent from upfront KRD. But really, you look at these recent studies where they're not including allogenic based on the data they've seen so far. Just 2 or 3 slides on various salvage chemotherapy options. So in the previous studies that I showed you, various regimens have been used. They've used VTD paste, they've used VRD paste, they've used VRD, they've used KRD sometimes, but nothing is uniform. You don't have a standardized prospective, very recent studies that have looked at 1 or 2 regimens alone. So essentially, everything has been basketed together. Now, this is a very nice study that looks at KD pace. It's a small study. It's just 10 patients from the US. The overall response rates, again, very good in a patient with relapsed plasma cell leukemia. The overall response rate is close to 80%. But really what's important is these regimens can only be used as a bridge. They cannot be, I mean, a KD pace cannot be used beyond 3 or 4 cycles. And you can see that the overall response rates in a bridging cohort is 94%. But in a non-bridging cohort, it's only about 52%. So the PFS is also better. That is, if you bridge, if you give this regimen to transplant or any other kind of bridge later, the PFS is almost 8 months versus only about 2 months if there is no bridging available. And again, a very poorly responding group, 94% have received bortezomib, 20% are triple refractory, that is, they've also received daratumumab before. Just little information on daratumumab. Again, these are studies that have used daratumumab in the relapse setting mostly. But what you see is the PFS is superior with daratumumab when you compare it to all the other regimens. It's 19 months versus 3 months. Overall survival, again, excellent, 21 versus 5 months. But it's important that the patient achieve a partial response. And then, of course, the overall survival is going to be better. Again, this slide reiterates the importance of a bridging strategy. So a patient is going to achieve a superior overall survival with hopefully an autologous transplant and allogenic. And some of these patients have not received an autologous stem cell transplant at all. So those who are bridged to something else seem to be doing better. Some ongoing studies in the West. There are phase 2 trials on NK cells in combination with ilotuzumab, which is a CS1 antibody, lenalidomide, and high-dose MEL before transplant. There's another study on panobinostat with gem, busulfan, and melphalan. As you may be aware, panobinostat as an agent for relapsed refractory was actually, the approval of it was FDA withdrawn because they were not able to show ongoing good efficacy with the drug. There are studies, of course, on CAR-T and several other cellular therapy bispecific antibodies that are ongoing. We don't have a lot of information yet. This is one study from China that is a phase 1 study on anti-BCMA CAR-T. They've just included 2 patients with a primary plasma cell leukemia. One has had a CR with a PFS of 307 days and the other a VGPR with a PFS which was a little more than 3 months. This is a slide. This is a patient of ours. It was a 64-year-old who came in with these skin lesions all over for about 4 or 5 months and constitution symptoms. There was loss of appetite and loss of weight. The WBC was about 1.2 lakhs. In plasma cell leukemias, they do have, they present with thrombocytopenia often. This patient also had a platelet count of about 75,000-80,000. And a biopsy from the skin lesion was done, which actually it was studied with plasma cells which were light chain restricted. And Sir did mention about our work on MALDI-TOF mass spectrometry. It is a very sensitive technique. It is also being used as an MRD marker in comparison to flow cytometry based assessment. And we use this for all our patients at diagnosis and follow-up. I mean, these are ongoing studies, and we do see that even when the SFLC and the IFE is normalized, some of them do continue to have an M spike. So what you see here in the diagram is an M spike, and we're really studying prospectively what this will signify. Now, since MALDI-TOF mass spectrometry is a very it's a very sensitive technique, it can actually identify small quantities of M protein for a very long duration. So one really needs to study the significance of this. We did file a patent for this process in 2020 in our lab in the Department of Molecular Oncology at the Adyar Cancer Institute. And what we're essentially doing is we've developed a very inexpensive technique. Now, as you see with therapeutics from the West, there is a lot of, when the drugs reach India, they're very expensive. And we really see the same thing with diagnostics. A serum-free light chain and immunofixation is also very, very expensive. And sometimes it has a lot to do with the kits that we buy. So the cost, a lot of the costing actually goes into that. So again, when mass spectrometry, MALDI-TOF becomes available, when you start getting these kits, you can run them very easily on biotypers. These equipment are becoming available in many centers because of its use in microbiology. So you could really use the same equipment for this test as well. And what we do presently, we're running it on research mode. Even if a patient cannot afford an SFLC IFE, we actually run them prospectively. Of course, we will only be able to, we have comparison data with SFLC and IFE, but sometimes when they don't, when they don't have money for an SFLC and IFE, I find that this does help us, because it kind of, you can serially evaluate the M protein. You can see the quantity going up as well, and that has portended a relapse. Again, it's not across the board. This is some data we have, and we are collating it together. This is just these are the last couple of slides on various treatment algorithms. And like I mentioned earlier, a lot of the guidelines for plasma cell leukemia, they really depend on expert opinion. So of course, if you have a patient who's transplant eligible, please offer an auto transplant. Either if the patient has had a CR, an auto based on the EBMT data should suffice, or an auto allo would be better if the patient has not achieved a CR. But essentially what's important is we continue maintenance based on all of the studies. This is a study that is from the Europeans, and the next study is one from Dr. Gonzalez, who's from Mayo, Minnesota. Consolidation, you consolidate with some of these PI IMID triplets, but maintenance essentially try and keep the patient on PI and IMID plus minus DEXA. Again, these are just expert opinions, and there are very, very few prospective studies to address various questions. Thank you.
Thank you, Professor Nikita Mehra. Wonderful presentation. Such an in-depth work on this subject, which is relatively a small subject, but you have spent probably so much of your time understanding it and putting it across to us, and beautiful review of the literature. I never knew so much material existed on this subject. Fantastic, congratulations. We'll give you 5 minutes rest, during which we will just give the solution to the quiz to the guys here, and then we come back to you as well as all our discussants who are present here in very good numbers. And thanks to all of you for being here. They are all excited to discuss with you. So I'll just share my screen to give the answer to the Sunday quiz. So this Sunday quiz today was related to inclusions in the red cells. You were shown 6 peripheral blood film, and you were asked which one or more has got henge bodies. So these were the 6 blood films that were shown to you, and I must say that my feeling was that we would get a large number of correct answers. That didn't happen really. So probably it was worthwhile putting this up, because the main job of the quiz is education. So these are the answers. I'll come back to hinge bodies at the end. What you see over here is Romnowski stain, basophilic stippling. What you see number 5 is again a Romnowski stain on the left and Prussian blue stain on the right. And these are Pappenheimer bodies on the in the red cells. Number 4 is, of course, your friend Cabot rings, routine Romnowski stains. These are supravital stains, new methylene blue. And what you see over here, I think is the best seen over here, is the inclusion bodies. Then what you see over here is this dot-like structure, Romnowski stain, Howell-Jolly bodies. And this is what we had asked you. This is again supravital stain, new methylene blue, and these are hinge bodies. So the answer was actually 1. Okay, so I think it's my important duty to tell you exactly what they look like and why these were hinge bodies and others were not. So we'll discuss these 6 entities in next 5 minutes. So hinge bodies are formed by denaturation of the hemoglobin by oxidative stress. Very rarely they are also seen in some genetic abnormalities of hemoglobin. During the oxidative damage to the hemoglobin, there is formation of reactive oxygen species, and the ROS denatures the hemoglobin, precipitates it, and that precipitate is the hinge body. The macrophages in the spleen and as well as in liver can detect the hinge bodies, remove them, and that's the genesis of bite cell that you see in G6PD deficiency. Hinge bodies can only be seen in supravital stain, that is new methylene blue or brilliant crescent blue, whatever you're using. They are not seen in the Romnowski stain like Wright's or Jim cells. Hinge bodies are usually found closer to the inner surface of the RBC membrane, just inside the membrane. As you see, a lot of dot-like structure near the membrane, as against Howell-Jolly body, which you see in Romnowski stain, which can be anywhere in the cell. The commonest entity that you see in India is G6PD deficiency. And especially if some patients have been splenectomized, you can see in that. And the second one is abnormalities in the glutathione pathway. Howell-Jolly body is something simple. You see it left and right in a country like ours because of megaloblastic anemia. So these are dark purple, usually single, sometimes multiple spots in the cytoplasm of the red cell, seen by Jimsa or Wright stain. These are basophilic nuclear remnants. And typically, these are round or oval, as you see over here, round or little bit of oval structure, 1 micron across. Usually, they are just 1 per cell. And the disease that most commonly we see is megaloblastic anemia. It can also be seen after splenectomy or hyposplenism and some other severe hemolytic anemia. Inclusion bodies, and a large number of you call them hinge bodies. I understand because these were the 2 slides with the methylene, the supravital stain of new methyl blue. So what you see over here, where especially the arrows are there, are see, this one is the best one. Multiple inclusion bodies scattered all over. They are not just below the membrane, and they are not 1, 2, 3. There are 30s and 40s of them. These are inclusion bodies in the stain that you use for reticulocyte count. So these are a subtype of hinge bodies in a way, because these are ultimately by the same mechanism. These are seen in alpha thalassemia. Classically, what you see in India is the hemoglobin H disease. It's not very common. These bodies are the part of the hemoglobin that precipitate within the cytoplasm of the red cell due to insoluble nature of beta chains. So these are called inclusion bodies. Then Cabot ring is simple. You see in megaloblastic anemia most commonly, occasionally in myelodysplastic syndrome. It's in the Romnowski stain, that is Jimsa or Wright stain. These are like loops or rings or figure of 8. These are located in the cytoplasm. They typically color red, purple, and these are remnants of the mitotic tubules. Pappenheimer bodies. These are iron. So this is precipitated iron. So can show them on Prussian blue stain as you see over here. So, however, Jolly body and the Haynes bodies with the nuclear remnant, as against that, the Pappenheimer bodies are, which are located in the periphery of the cell, are inclusion bodies due to iron deposits. And visible in the right or Jimsa stain, Romnowski stain, best seen with Prussian blue. Common causes are sideroblastic anemia. They can be seen in megaloblastic anemia, hemoglobinopathy, and after splenectomy. Last is basophilic stippling. Of course, in India, you see this quite commonly because of the thalassemia minor. You can see it in lead poisoning, not very common nowadays, except for Ayurvedic medicines. And then very rare condition, but very interesting condition where 80% of red cell can show this is the P5' deficiency. We have one case which we saw about 20 years ago. So basophilic stippling, also known as punctate stippling, seen in right or Jimsa stain. These are fine or coarse granules scattered sort of all over the red cell. These are remnant of the RNA and the ribosomes. And in India, most commonly seen in thalassemia minor, and occasionally you can see it in lead poisoning. So the answer expected was 1. We got only 2 answers correct, only 2 correct answers. The second one at 11:48 a.m. was Dr. Rehan. So congratulations, Dr. Rehan, together with the winner who was fastest finger fast. You are the only other one who gave the correct answer. And the fastest finger fast is Dr. Umang Patel. So congratulations, Dr. Umang Patel. This came at 11:47. Dr. Umang Patel is molecular geneticist, director of Green Cross Genetic Lab Private Limited at Ahmedabad. I understand about 10 years ago, you published a paper on hemoglobinopathies. Last study, 5 to 7,000 in one of the Saudi hematology journal. So you are probably very close to hemoglobinopathy and it's easier for you to pick up the diagnosis. So congratulations. Send us your contact details and just email to me and we will send you your token of appreciation. Thank you. So that was the. Now we move on to the question and answer session. We'll be using the raise hand sign. Here we have Dr. Rajan Kapoor ready with this question.
Good afternoon, sir. First of all, excellent lecture, Nikita. Fantastic and compliments your I think Maldi-Toff is the way forward, and hopefully, as you said, if the cost comes down, it would be great for all of us to probably get things done by Maldi-Toff. It's heartening to know that such a good work is being held at your lab. So if you permit, I'll just share my experience, limited experience with the plasma cell leukemia. So as you said, it's a very rare. So transplant eligible, before DARA was available, we were using VDT paste across the line. And with VDT paste, the problem was many of them were not able to go for the transplant because of all those, what we can call as an induction mortality with the VDT paste itself. So second was we did try allo, 3 patients, and we burnt our fingers in 2 badly. So I think allo, as you pointed out, it's highly experimental. I really won't be recommending probably people going on with the consolidation with allo. Now what we have found of late, now we are using 4-drug induction with DARA, Carfel, POM and DEXA. So giving that induction, the patients to go into VGPR or more, we are doing an autologous. We are not doing a tandem auto. Rather than tandem auto, we are giving induction again for 2 cycles and then putting them for DARA maintenance. So we had 2 patients and thankfully they are doing well. So I feel I'd like to know your opinion and probably other discussants. A 4-drug induction, which includes probably a DARA and proteasome inhibitor or POM or a LEN, and followed by the same 2 more cycles, 2 to 3 cycles as what they had done in the master's trial or something, and go on for a DARA maintenance. So probably I'd like to take your opinion and all the other discussions. What do you think about the 4-drug induction for plasma cell leukemia?
So thank you for sharing your experience. You are a teacher, so very kind words. But again, I did tell sir that we were going to share our data, but it's so heterogeneous and the numbers are very low from a single center. I really didn't think it was meaningful. We had one patient who we gave DARA VRD to. And she achieved a CR. The patient had an autologous transplant. Could not afford DARA after transplant, but maybe got about 2 or 3 cycles of DARA with VRD consolidation. But 8 months after the auto transplant, relapsed. This was a patient with extensive extramedullary disease as well. So I think it boils down to logistics, the financial constraints, and if they don't have the strategy you mentioned would be ideal. But why not a tandem auto? I mean, you mentioned. So you're on mute.
Yeah, we did try 1 or 2 tandem. What happened was before that DARA was available, when we said, so people who go into CR, more than VGPIR, then only after autologous, then only there is a scope of a tandem, because otherwise if they are still having a disease, if they have not gone into CR, I don't think so there's any point in giving second auto to them. What we are seeing with DARA KPD, they are, it's a very limited experience, very small number as such. So we found that after autologous, giving more DARA and putting them on maintenance, so that is our strategy as of now. But yeah, if they go into CR, yes, tandem does make a difference. Though that's and sometimes we have that, like now the center where I am, the cryopreservation is not that good. So taking the stem cell for 2 autos sometimes not feasible. So earlier we were doing that, but with the availability of DARA, I think it does give us more ammo against plasma.
What was the cytogenetic risk stratification?
Yeah, so we had, like you said, 11, 14 also, and one we were complex cytogenetics. So there were 2 or 3 cytogenetic abnormalities. Venetoclax means we haven't used it, but that's very encouraging paper. We were thinking someone comes out to be 11, 14, but only hitch is that a very high dose of venetoclax is required, and they go into TLS also, as you had mentioned. So, you have any experience venetoclax? I personally haven't.
We don't have any experience with venetoclax.
Thank you.
Thank you, Rajan. Aditya.
Good afternoon, everyone. Thanks a lot for the excellent talk, ma'am. So my question is regarding the natural history of the disease, especially the secondary plasma cell leukemia part. So as you have already briefly mentioned that with the increasing survival of the increasing overall survival of the multiple myeloma patients, we are increasingly seeing secondary PCL patients later in the natural history of the disease. So how does the sequencing of various anti-myeloma regimens, or what I particularly want to know is how much many times we use alkylators in real world practice, using melphalan and sometimes a combination of bendamustine with imids and dexamethasone. So what do you think is the relative attribution of these regimens to the incidence of secondary PCL in the natural history of any given patient, and whether we can mitigate it with the choice of regimens?
Thank you for the question, Dr. Aditya. Again, based on literature that we have, even secondary plasma cell leukemias, the outcomes are very low. And that's really what we see in our real world practice also. And a lot of the times, it's not just plasma cells that spill over. They have a lot of extramedullary disease, sometimes CNS myeloma. I've seen many patients with extensive skin lesions, and their outcomes are very, very bad. Again, we don't have any patient who we've been able to offer daratumumab to for secondary plasma cell leukemia. And as we speak, we have a patient presently on bendamustine who's got plasma cell leukemia. So again, very, very difficult to comment, but all I can say is patients with secondary plasma cell leukemia, they're usually very sick. And it's not disease that's just confined to the peripheral blood. It is extramedullary. So their outcomes are, it really, I'm not very sure of how some of these chemotherapy protocols would really work. But could you share some of your experience from PGI for...
So, ma'am, as you have already highlighted, so most of the patients that we see with plasma cell leukemia, they have poor poor performance status, and generally the survival we have seen is for few months only. So whether it is because of the progressive disease or complications because of the regimen related toxicity, the overall survival is not more than few months. This is what I can comment at this point. Ma'am, another question that I wanted to ask was regarding the choice of regimen. So you mentioned about TP53 mutation positivity in about 50% or so patients. So does the choice of initial therapy changes whether or not you have TP53 positivity at baseline in PCL patients?
Again, very limited data. The data that I've shown, everything is pooled together. And of course, patients with 17p deletions are going to do worse than the category without. Sequencing, what is the data on upfront? You're talking about primary plasma cell leukemia. Data on upfront daratumumab is extremely, in fact, there's more data on upfront carfilzomib and in primary plasma cell leukemia. So in terms of sequencing, because they've been so poorly represented in clinical trials, we really don't have a lot of information. The key seems to be achieve a very deep response, hopefully a complete response, consolidated, and of course, continue maintenance. What regimen, what is preferred over the other? There's very, very sparse information. There's information on BRD, KRD, and like I mentioned, that PAD and it alternating with VCD. So very difficult to say this has to be given. In fact, when we've discussed with experts like Dr. Vincent Rajkumar and Dr. Shaji Kumar, actually Dr. Vincent Rajkumar keeps telling us about how even when you look at the relapse studies for daratumumab, you don't see in the high risk, the quantum of benefit seems to be lower than in those with standard risk. So if you have to, we're not trying to extrapolate, but if you do extrapolate a little from that, if the patient has a high risk cytogenetic abnormality upfront, is there going to be, I mean, we need to look at data, but is daratumumab really going to change that? According to the experts, based on the information for relapsed refractory, it isn't as convincing. Daratumumab hasn't shown a far better. So high risk is always going to do very poorly.
Fine. Thank you, ma'am.
Thank you, Aditya. Before we come to Aditya, one question from the audience. Dr. Pujita wants to know about this CNS infiltration of plasma cell leukemia. How do you handle them?
So again, thank you for the question, Dr. Pujita. There's very limited data on intrathecal chemotherapy. There's some data on ixazomib, which is not available, pomalidomide. The study, I mean, I showed the study from Stanford on auto and allo. Even they had 2 patients who failed quickly with CNS involvement of plasma cell leukemia. But really, there are no standard protocols. And from what we see, I have seen in the last 4 years, I've seen about 1 patient who had a 414, did excellently on PI IMiD upfront. But when the patient developed a plasma cell leukemia, the patient's performance status was very poor. So intrathecal chemotherapy, we tried pomalidomide, but we really didn't see it working so much. And also because the performance status was very poor. Tolerance to chemotherapy was also poor.
Thank you. Dr. Aditi.
Thank you, ma'am. Ma'am, what is the frequency of translocation 1114 in primary plasma cell leukemia? And second question is, what is the role of MRD and how does it change our management currently in the treatment of plasma cell leukemia?
Thank you, Dr. Aditi. So for primary plasma cell leukemia, the 1114 frequency is anywhere between 25 and about 70%. But when you look at all the studies together, apparently the ballpark is around 50% for 1114. Now that 1114 translocation in non-primary plasma cell leukemia, that is regular multiple myelomas, is only is about 20%. So it is significantly present in primary plasma cell leukemia. With regard to MRD, again, just like multiple myeloma, it offers prognostic information. If someone is MRD negative, their outcomes further on are going to do better than those who are MRD positive. But do you have, rather, if I can extrapolate from that same, the EBMT study that I showed from 2022, if the patient is in CR, then you can kind of avoid an allo. So if you have to extrapolate that from that, if the patient is MRD negative, maybe you can make a case for, oftentimes offering an allo is very difficult, but maybe you could do maybe a tandem auto, or maintain that MRD negativity with auto followed by consolidation and maintenance. For now, it is prognostic. Can you change information or can you reduce, de-intensify treatment because they're MRD negative? We don't have such information for primary plasma cell leukemia at all. And for multiple myeloma, there is some information on de-intensifying, but for primary plasma cell leukemia, I think we should not do that. So even if they're MRD negative, whatever your treatment strategy is, was planned based on the patient's access to treatment and so many other factors, financial, etc., you should be planning the same and continuing it. We shouldn't make changes because the patient became MRD negative. But again, very scarce information in primary plasma cell leukemia.
And ma'am, what regimen would you prefer when venetoclax is used upfront in a patient with 11-14 translocation?
So there is no information on upfront venetoclax in primary plasma cell leukemia. And like I mentioned, the study from Mayo Clinic, which was a case report, they have given daratumumab, bortezomib, dexamethasone, along with venetoclax.
Okay, thank you, ma'am.
Thank you, Dr. Aditi. Dr. Roshni, we will come to you. We'll take one more question from the audience. Dr. Kannan has been using mass spectroscopy for finding the type of amyloid. And he wants to know from your side how useful you found it in the quantification of the paraprotein. And from my side, I want to add, you said you are using it for the research protocols, but are you also offering it to the patient for clinical care?
Thank you, Dr. Kannan. One thing is there are studies that have looked at, again from Mayo Clinic, where they've looked at quantifying the protein, and they basically take into account, they look at the area under the curves of the monoclonal protein and the entire M protein, and they compare it along with the serum immunoglobulin by nephrometry. So there is a formula that's already defined. We are looking at various ways to do it, but we've not started quantifying it yet. We're looking at various ways, but we've not started using the same. I mean, that's kind of an ongoing project. So no, we are not quantifying it for everyone. We're just learning how to quantify it right now. And we're not even going by the Mayo formula because of various issues that we have with nephrometry, etc. The thing that you mentioned about, it's excellent that you're typing the amyloid by mass spectrometry. But over here, for amyloid, there's actually a different pattern that you can see in the M protein. We've seen it very infrequently. So you can kind of tell that, yes, this protein might be due to amyloidosis. The glycosylation of light chains leads to it's a polytypic pattern. In terms of, this is absolutely running on research, on a research mode, and we do not offer this in the clinical care. Now, where we find it valuable or useful is patients with non-secretory multiple myeloma, or light chain only. Anyway, you will pick up kappa or lambda, but these non-secretory, group, you can actually pick up more by MALDI-TOF mass spectrometry. Again, non-secretory is only about 2% or less than 5%. So very infrequently, this has helped us in the non-secretory group. We don't offer it yet. I think the plan is, of course, there are several things in the pipeline, and once everything is done, we will start it as clinical, we will give it as clinical service. But right now, all our patients, if they are willing, they consent, they get it at baseline, and then they get it frequently. And my patients like to know their data. So they come and they sit with me and they look at their serial M proteins. Then they tell me, show me the IFE, SFLC, and moldy turf.
Thank you. Dr. Roshni.
Good morning. I really liked your talk. Coming to the consensus, what is the consensus of use of anthracycline as first-line therapy?
Thank you, ma'am. Again, like Rajan sir told us, they don't use a lot of anthracyclines. There is some data, and the data that we have is from IFM that has looked at PAD with VCD. There they've used anthracyclines, but we did not see magnificent survival outcomes with that. Again, VTD pace, VRD pace, the expert opinion is really that if patients don't respond to a VRD, KRD, then you give a VTD pace or VRD pace. And the other is if a patient has a lot of extramedullary disease, then you do VTD pace, VRD pace. So has it, I mean, if there is a lot of extramedullary disease and the patient is fit, we would want to offer it. But at the end of the day, whatever we give and VTD pace, VRD pace, we can only give about 2 cycles, not even 3 or 4 cycles. Even if we're giving 1 or 2 cycles, we should ensure that we're at least continuing a VTD or VRD or whatever induction protocol that we plan. Deepening responses is key. So whether it's anthracycline or not, whether it's DCEP or anything, just providing a deep response is probably most important before a transplant.
The second is my experience. I had a case in 2013 with plasma cell leukemia, and we used the old definition. And this lady was very poor. So actually, because it was plasma cell leukemia, I dissuaded her from treatment. I said, the survival is poor, but this family said, do whatever you want. So naturally, she was not a candidate for transplant. So I gave her VCT and then followed up with lenalidomide and dex maintenance. This patient is alive today. In those days, we didn't have flow cytometry. We didn't use it. We didn't do cytogenetics. So are there any unusual responders like this? And later on, what happened, I had planned to continue lenalidomide maintenance indefinitely. But because of thrombocytopenia, I mean, we finally stopped it.
And that's, thank you for sharing your experience. But again, unusual responders, there was a paper on this, again, I think it was from Mayo Clinic on long-term responders, but that was not just for primary plasma cell leukemia, it was for all patients with multiple myeloma. It would have been interesting seeing what the cytogenetic profile for this patient was. Was it 1114 or was it a hyperdiploidy? Because as we know in multiple myeloma, hyperdiploidies, they go on to do very well. Now, there is mention in some of these papers. In one paper, there was mention of multiple myeloma wherein the bone marrow is studied with plasma cells and there can be an occasional spillover into the peripheral blood. And these patients apparently do better than the other primary plasma cell leukemias. So maybe this patient was kind of one of those spillover kind of cases where it was just studied with, I mean, it was just a spillover, did not have too many of the other primary plasma cell leukemia characteristics. I'm really not.
Was she actually behaving like a multiple myeloma rather than a plasma cell leukemia? The other.
Sorry.
When we get stuck with lenalidomide due to thrombocytopenia, what should we do?
Ma'am, one is, yes, we reduce it to 5 mg, and if we cannot even do that, we actually switch back to thalidomide. We have an issue, one is thrombocytopenia, but the other is the skin rash. And even if we have used desensitization protocols, that prednisolone tapering course over 30 days, we see some patients continuing to have the skin rash. So at least a thalidomide would be good enough, 50 milligram maintenance every day, and they tolerate it very well.
that thalidomide is to really please ourselves, or will it make an impact on the progression-free survival? These are for patients who are now going to indefinitely take lenalidomide. They've crossed 3 years, 4 years, you know, this kind of group, not the initial maintenance.
Again, if we don't have randomized studies, it's going to be difficult to give one answer. I agree that we're probably, I mean, we're doing it more for ourselves, but there's very good data on thalidomide maintenance. So I'm not sure if it is just kind of, I'm sure it's far more than placebo. It is an active anti-myeloma agent. So if you cannot give lenalidomide, thalidomide would be good enough.
And my final question is regarding the DARA addition in frontline. If the patient says that DARA, or you know, what would you do? Would you give daratumumab, or would you go with the standard of care, which is, you know, right now BCD or VRD?
Ma'am, again, these are discussions. Of course, we look into the logistics, access, etc. We don't even bring it up if it is even there is a 10% possibility that, because it ends up kind of playing in their minds that we cannot we cannot afford this treatment. Having said that, we do talk about the results of daratumumab upfront. That is, they led to deeper responses. They were better MRD negative rates. Should it change practice? I'm not sure if something like this, I mean, we can talk about it as practice changing, given the cost constraints. So yes, if a patient is, I mean, if the goal is to achieve deep responses, but to certainly bridge or follow it up with an autologous stem cell transplant, then maybe we will be able to get away with a VRD pace, a VTD pace. We can just do a daratumumab with VRD. But like I talked about the patient, there were multiple cytogenetic abnormalities. The primary was 414, but there was 17p deletion, extensive extramedullary. DARA VRD was given, excellent deep responses, consolidated with the transplant, not willing for any further. They just wanted a plain VRD or chemotherapy. And there was a relapse after 8 months. So it's good for deepening response initially, but there needs to be several other things that follow.
Thank you so much.
Thank you, Roshni. Before we come to Dr. Srijesh, one more question from the audience. Dr. Sumit Mir wants to know, how do you decide whom to give VDT pace and whom to give Dara Carfil?
Thank you, Dr. Sumit. I think it boils down to cost. That's it. And of course, in the relapse setting, if the patient can afford treatment, they should be getting DKPD. Possibly, there is some initial data that shows very deep responses. VTD pace, we kind of, for the plasma cell leukemias, we try and give it initially. So of course, that is no longer an option, but we did have a patient with plasma cell leukemia, extensive extramedullary disease, where at relapse, we gave KPD alone. They could not afford daratumumab. They had received Dara previously. On KPD, the patient had relapse. I mean, there was an acute spinal cord compression. And then we followed this up with VTD pace. Now with VTD pace, the patient went into CR and was MRD negative, actually. Again, performance status at relapse. If the performance status is very good, we should be giving VTD pace, or there is an ongoing study on daratumumab with DCEP. So if you can't give anthracyclines for whatever reason, then Dara DCEP seems to again, we've used that regimen once, and the patient took it fairly well.
Thank you. Dr. Srijesh?
Yeah, nice update. I have just one question from the laboratory side. So in your practice, currently, do you use 5% or 20% cutoff to diagnose plasma cell leukemia? And suppose you have a patient with the plasma cell, circulating plasma cells between 1 and 5%. Do you consider it as a high-risk myeloma, irrespective of other cytogenetic and other laboratory parameters?
Thank you, Dr. Srijesh. Again, we look at all the parameters, but yes, I think as soon as we see plasma cells in the peripheral blood, we don't want to give a Cybody, we don't want to give a VTD, we give a VRD. There are some patients where they say it's occasional plasma cells. We cannot even give the percentage. So yes, we do VRD, but we don't for less than 5%, we would not give VTD, PACE or DCP or any of that. We will ensure the patient is receiving a PI IMID triplet and hopefully a VRD.
Thank you, Srijesh. So before we come to Tejaswini, once again, a question from the audience. There are a couple of questions, in fact, related to this. If at all you can answer this, what is the cost of the machine for doing the multi-TOF, and what is the recurrent expenditure that you are facing for doing this test, even in the research setting?
So one is the machine that we use, that is quite, it's actually a MALDI-TOF mass spectrometry from Brucker, which is a German-based company. But that was brought, that was got on a research project by my mentor and guide, Dr. T. Rajkumar. So we're not even talking about, and that equipment runs into a few crores. But you have a biotyper by Brucker. So it's a small device that you can place on a tabletop, and that is used for microbiological evaluation. So some centers have already got it, and it's outstanding for microbiology because you can get the reports, microbiological identification in less than 1 hour. Now, the beauty of this is when you look at immunofixation electrophoresis, you have only that many samples that you can run. It's very labor intensive. But a MALDI-TOF, when you have the samples ready, it's a 96 well steel plate. So you can actually load 96 samples and you'll have the reports in 3-4 hours. So we try and we pull samples and use them. Regarding the biotyper, I don't want to, I know it is less than 1 crore. I don't want to tell you the exact amount because I'm really not sure, but I do know many centers have started getting it. So the study from Mayo Clinic was actually done on that biotyper. The cost, again, it's, my mentor in the lab is very, very generous, but I can tell you it is very cheap because what you do in the Mayo Clinic, it's actually the antibody that you have to source. So you have to use a kappa and you have to use these streptavidin beads. And the antibody is very expensive. We bought it from Thermo Fisher. And the very minute quantities that will get over in some time. But this is actually a reagent-based study. So what we used is acetonitrile. Acetonitrile is very, very inexpensive. So the cost of preparing the sample is very, very low. I think once a biotyper can be made available in your center, this won't. This really will. I'm hoping this technology also takes off, and we will do everything to ensure the costs are kept low for this kit.
Thank you. Dr. Tejaswini.
Good afternoon, ma'am. It was very exciting. The talk was exciting. And when I received the invite, I just accepted it immediately. And the wait, like when will ma'am's talk come? And finally, today we have heard you talk. So I also have a question on MALDI-TOF. So I wanted to know how you developed this, like the journey from like how you got the idea and how you finally got the procedure, how you came up with the whole process a little more elaborately, because one of my seniors in our hospital, they wanted to do a study on one of the complications of transplant, and they wanted to identify a newer marker for that complication. So how was it that you developed this MALDI-TOF as a technique for detecting M protein?
Thank you, Dr. Tejaswini. I actually visited Mayo, Minnesota in 2019, and I spent a week with Dr. Vincent Rajkumar and Dr. Shaji Kumar in their clinic. And I was able to see how they kind of they were using clinically MALDI-TOF mass spectrometry as well and comparing it with the other results. I was not able to visit the facility because it was far away. But when I came back, I had it at the back of my mind that this was available in the department. Now, at that time, I had a rejection, and I had submitted a grant for the project that I'm actually presently working on. And I wasn't doing very much. So I asked my boss if we could kind of replicate this technique to see if it worked from Mayo Clinic. And he said, by all means, you can do everything by yourself, but go ahead. We have a very nice, I mean, there is a proteomics division. And initially it took about, we went over all the studies. It took about 3 or 4 weeks to source the antibodies and everything. And I think I needed ethics committee approval for my biomarker project. But once everything was ready, we started working on the Mayo Clinic technique. And it was very exciting when we saw it worked. So we spoke with my guide, Dr. Rajkumar, and he kind of said, you need to look at other ways of identifying this M protein by MALDI-TOF. And the senior scientist who I work with, Professor Gopal, he said the protein was very, very stable. So amidst many, many proteins, we were able to beautifully see this spike. We had the kappa and lambda standard also. So suddenly he said, why don't we look at running this reagent? And we went into this with no expectation, but we were amazed when we saw the same results. So then we subsequently started comparing it with the Mayo Clinic technique, and there were identical images for the two. So of course, we did some validation along with the Mayo Clinic technique, but then we became very comfortable very, very early to kind of to start running our technique alone. So it does help when you have rejection, because then you find new opportunities. I did not want to not do anything, and my boss was very kind in letting me work on this. And it was very exciting because we filed the patent actually right before the first nationwide lockdown in March 2020. We had sufficient samples, and ever since it's ongoing.
I heard the previous question regarding amyloidosis, and I came up with another thought that one of my colleagues, she's working on amyloidosis for her DRNB thesis. So if you would agree, both of us could together visit your lab once.
Definitely. I will share my email address and we'll talk later.
Thank you.
Thank you, Tejaswini. So one more question from the audience. Again, going back to venetoclax. So if you have 11-14 plasma cell leukemia, can you use venetoclax borte upfront to transplant and continue with the venetoclax bortezomib maintenance? Your opinion?
So like I mentioned, there is no data on upfront venetoclax for 11-14. There is data on relapsed refractory multiple myeloma from the Bellini study. But having said that, there are very few case reports on venetoclax. We saw one report on single agent venetoclax, one on in combination with other treatment. But there are reports, there is actually one report in BMJ where it hasn't worked. So I think if we can, just like the Czech Republic study, where they've looked at expressions of not just BCL2, they've also looked at BCL XL and MCL1. And if we can kind of see that the BCL1 XL and MCL1 expression is low, venetoclax works better. Again, these might be very difficult for us to run in our centers, but there's very limited data. I'm very sure we will have more data as we kind of move along. At this stage, very, very limited data, but very gratifying that single agent worked for the patient.
Thank you. Dr. Yashwant?
Any good subset in plasma cell leukemia?
So thank you, Dr. Yashwant. Again, 11-14, There is mention of 1114 being better than the other subtypes. But is 1114 plasma cell leukemia better than 1114 multiple myeloma? The answer is no, because it's not just the 1114 that's driving the disease in primary plasma cell leukemia. We did go over all those molecular changes, complex cytogenetics, the epigenetic modifications where there's hypomethylation. So among all the groups, 1114 might be better, but again, there's no clear data to show that it is better than the other categories. To put it the other way around, the 17p deletion will be very bad. The other is MYC amplifications. There's some data that patients with MYC amplifications in primary plasma cell leukemia have very poor outcomes.
I mean, what recent drugs you are very much hopeful about future recent drugs?
I think for primary plasma cell leukemia, among all the drugs, it's venetoclax. There were studies on selinexor. Basically, selinexor, at least the biological basis was that it would work better for 17p deletion. Based on the studies we have, that is not the case. So among the newer drugs, there's again very limited data on anti-BCMA, belantamab mafodotin. Again, while it was a drug we were all very excited about, the progression-free survival is only about 2 months. This is what Dr. Vincent Rajkumar mentioned recently on one of the meetings from their data from their institute. So I'm not particularly excited about any newer drug except for maybe venetoclax.
And ma'am, regarding Indian study, any Indian study with primary and secondary plasma cell leukemia?
So Indian studies, there are Indian studies. The data is very, very heterogeneous and very different regimens. Many old regimens have been used and some protocols with IMiDs. There is limited data that's available, and the outcomes don't seem to be very different from what there is in the West.
Thank you, Yashwant. One more question from the audience. Dr. Sumit Mir wants to know, you talked about the tandem auto for primary cases, but what about secondary cases? Will you prefer auto allo for those cases? Secondary PCL.
Secondary plasma cell leukemia. Thank you, Dr. Sumit. I'm again, their prognosis, their outcomes are very poor. Their performance status. I mean, getting to an auto allo. There was one patient who'd actually failed auto, and we talked about it was less than a year. So we did talk about allogenic in that setting. We were not very sure if doing another auto would have really helped. But there are too many issues we face in terms of even trying to be able to arrange for a donor, the logistics, etc. I think if the performance status is reasonable and if the option is available, we should be offering an auto allo. Even in a relapse setting, again, if we can achieve good responses with any chemotherapy regimen, maybe, yes, we shouldn't stop with an auto and we should be doing more. An auto allo would be feasible. How possible is it in the real world is really the question.
Thank you. One last question, Dr. Stalin.
Yeah, Nikita, that was an excellent talk. So most of my questions were answered. So how long will you continue the maintenance post-transplant in a PCL? So myeloma, we stop it after 2 to 3 years if the patient is not having a relapse or so. So for a plasma cell, I have a case which is on bortezomib maintenance for the past 5 years. So are you using a doublet maintenance like what you use in a high-risk myeloma? And if at all, so how long will you continue if the patient is not relapsing and there was a no MSPEC post-transplant?
Thank you, Dr. Stalin. We would continue maintenance indefinitely. If it's a clear-cut plasma cell leukemia, that is by the older definition, more than 20%, but I'm not sure we will do anything differently for above 5% also. We would try and continue an IMiD PI maintenance indefinitely. Again, the survivals, like you saw, the median survivals were all 2 to 3 years only. So we wouldn't stop it. We wouldn't want to stop it at any point. Also, we don't have access to all the newer drugs to all these clinical trials. So we would not want to stop maintenance for patients with plasma cell leukemia.
Are you considering the doublet maintenance like botilan, which is being used for high risk myeloma?
Absolutely. We are continuing. We are giving a PI IMiD maintenance to patients with plasma cell leukemia.
Yeah, thank you. Thank you, Nikita.
Thank you, Stalin. One more question has come up from Dr. Aditya.
Ma'am, I just wanted to know your thoughts on the fact that, like you mentioned earlier, that a transient spillover from the marrow could lead to homing of abnormal plasma cells in the extramedullary space, whether it is CNS or it is like pleural space, pleural effusion, or like you showed the cutaneous involvement. So in future, what do you think? Will plasma cell leukemia will continue to remain as a separate entity, or the patients with the extensive extramedullary involvement, which indirectly reflects a kind of extramedullary spillover, will they be classified together as a bigger high risk category?
So at least, thank you, Dr. Aditya, at least by plasma cell leukemia, going by the molecular pathogenesis itself, like CD56 is low, then there's this contribution of VLA1, VLA4, LF1, all these factors that lead to the cells detaching from the marrow and going all over. Again, another concept that I did not talk about earlier is that some patients with plasma cell, this was again mentioned in one of a very good international publication. In some of the patients with extensive primary plasma cell leukemia, the peripheral blood plasma cells can actually drop and you can see a lot of extramedullary disease. So what they're really requesting or they want to club is these patients with extensive extramedullary disease and primary plasma cell leukemia as one. It is possible that extensive extramedullary and plasma cell leukemia are probably behaving. They will be molecularly also very similar. There are very high rates of hepatosplenomegaly in plasma cell leukemia. Primary plasma cell leukemia, again, bone disease is very low. I mean, I think it will always be categorized differently, and it will be more towards extramedullary than the multiple myeloma. I'm not sure if I answered your question, but
thanks a lot for your response. And one last thing that I wanted to ask, since now I can see Dr. Chirag sir in the picture. So he mentioned about the principle of patient first whenever we are like dealing with patients, and whenever we are dealing with rare case scenarios like plasma cell leukemia with CNS involvement or some extensive extramedullary involvement. So like we do not have a clear answer whether DARA based therapy has superior outcomes in the setting of plasma cell leukemia as compared to VDT based. So, and we sir alluded to the fact that a single hefty medical bill is sufficient enough to push a family below to BPL status. So I think this is one scenario where I would like seek your opinion. What should a newly passed out hematologist should do?
I mean, as Sir very nicely pointed out, there are enough and more studies. There's one ongoing study which is led by Dr. Shankar Prinja from PGI Chandigarh, of which we're a part, where we look at out-of-pocket expenses and catastrophic health expenses. And there is something we've written recently. Once it's published, I'll share it. But really, we're not speaking enough about the cost involved in diagnostics. For multiple myeloma diagnostics also, they're very, very expensive, like for many other malignancies. So, you know, if a patient is not willing to do an IFE SFLC or even a PET CT, or even if low dose CT is not possible, just because we need beautiful Excel sheets, we should not force them to do tests. We can do, even if the oligosecretory and an M protein is only 0.8 grams per deciliter, no problem. We will use that. We will do simple bone morphology, examination later on, if they cannot pay for an MRD, if they cannot pay for a fish, it is all right, because a lot of these things have actually not led to, they've not changed things significantly. So I think we need to be very mindful of when we talk to patients and their caregivers, not by themselves. We need to be speaking along with their caregivers also to really assess their financial situation, not just financial situation. If my patient says, I cannot come to you every week for treatment, I can't come to you for injections, let's not force them to take Carfilzomib upfront, or even if they say, I can't come for Velcade. We were actually able to talk to the Tamil Nadu, we have a Tamil Nadu insurance scheme, the CMCHIs, and we said, we cannot have our patients come every week for Bortezomib, you have to give the injections. So they were actually willing later on. It took some time, but then patients were able to take the injections. Then there were locally. Then there are some who say, I will not take injections, you give me tablets. So there's very good data on Lendex. In fact, there's data on Lendex in primary plasma cell leukemia itself. So why not, based on the first study, just give them Lendex. And upfront daratumumab, yes, MRD negativity is higher. Where is the data on overall survival? Because really there are practice changing studies are only on the basis of two things: an improvement in overall survival and improvement in quality of life. So don't even entertain these discussions. Never bring it up to patients if they're on the borderline. They're not very sure they can pay for daratumumab, because there's so much guilt we put into the patients, and the guilt on their caregivers. When we tell them, what, this drug is available, and if you don't give it, these are the losses to you. Having them sell property and everything just for some extra treatment. I think we can concentrate on, we have some access to some of good access to PI and IMIDs. When you compare it to LMIC, the other LMICs, like we were reviewing the data for a paper on Africa, their access to just simple lenalidomide and bortezomib is so poor. And hopefully a patient who's transplant eligible can reach transplant centers. There are some support schemes that are available through we have so many schemes that I don't want to list out. So hopefully we can at least get those things for them. And, we don't have to talk about the hi-fi things. We talk about everything only to those who can access daratumumab. Then let's go into the details of the upfront trials of daratumumab, MRD, what the PFS improvement means, the fact that there's no mature data on overall survival. But they need to be lengthy discussions, and Sir put it so well, Chirag sir, that be a patient advocate. So understand them, listen to them, and only then carry forward discussions. We cannot put across everything to them. And the worst thing is, I've given you all the options, you decide. I think that shouldn't be the way. Sometimes they all have to be joint decisions. We don't decide, no maternalistic attitude by us. It should always be a joint decision, but also understanding what they can really access, and understanding what we can provide, and always telling them that we don't have all the answers. It's very, very important to be as open and transparent as possible.
Thank you, Dr.
Thank you, ma'am.
Thank you, Professor Nikita Mehra, for that wonderful talk and your clarity of thoughts, handling all these questions and giving them very practical and scientific answers. It was wonderful. Great education. Thanks, Chirag, also. And for official vote of thanks, we have Dr. Manoj Kumar.
I was just listening, and I just wanted to compliment Professor Nikita for, finishing a textbook in 1.5 hours on plasma cell leukemia, I would say. It was wonderful, and the question answer sessions were extremely wonderful as well. A big thank you to Professor Dr. Chirag Shah for a very interesting pulse of wisdom, patients, advocate. And I guess many of us who are listening to you today, we probably would put it in our clinical practice. All the expert discussions today, Dr. Abhishek Dudatra, Dr. Aditi Shah, Dr. Aditya, Dr. Ankit, Dr. Dharma Chaudhary, Dr. Dipanjan, Dr. Kunjan, Dr. Nidhi, Dr. Jayachandran, Dr. Prashant, Colonel Ranjan Kapoor, Dr. Ramesh, Dr. Roshni Pandey, Dr. Shilpa, Dr. Srinath, Dr. Shijesh, Dr. Stalin, Dr. Tejashwini, Dr. Vikas Goel, and Dr. Yashwant. And last but not the least, to Professor Dr. M.B. Agarwal sir for another wonderful webinar. Please don't forget tomorrow, best of EHA, I think 6:30, right, sir? 6:30?
6:25.
6:25. Another marathon next week. Thank you, and all of you have a wonderful Sunday ahead.
Thank you and bye-bye.
Thank you.
Bye.
Bye-bye.